Hi, my name is Marla Scott. I'm a fellow at Cedars Sinai, and I'm honored to share my research with you today. I have no disclosures. Endometriosis is a common disease that affects at least 10% of women and is associated with a slight increased risk of ovarian cancer compared to the baseline population. Clear cell and endometrioid histologies are the most closely associated and implicated with endometriosis. Clinical and epidemiologic studies have been largely limited to small retrospective cohorts given to the rarity of these histologies and have had varying results of impact of endometriosis on ovarian cancer and prognosis. We aim to better understand the clinical and epidemiologic characteristics of clear cell and endometrioid ovarian cancer with and without a concurrent diagnosis of endometriosis, as well as its impact on outcomes. After IRB approval, we identified all patients with clear cell or endometrioid ovarian cancer diagnosed between 2005 and 2020. Patients with mixed histologies were excluded. Standard statistical analyses were used to compare the groups and calculate survival. A total of 190 patients were identified with 115 clear cell and 75 endometrioid histology, making up 60 and 40% of the cohort respectively. 125 patients, or 65% of the cohort, had concurrent endometriosis at the time of diagnosis. 22% of those patients had atypical endometriosis, which was more common in clear cell. Endometrioma was common, occurring in 44% of patients with endometriosis, and again occurred more commonly in clear cell. 15%, or 29 patients in the total cohort, had a synchronous primary. They occurred more frequently with endometrioid histology, and 66% of patients with a synchronous primary had concurrent endometriosis. MMR protein data was available in 35% of the cohort. 5% of patients had a mismatch repair deficiency, with 9 of the 10 patients being endometrioid histology. When comparing the two groups, as shown in the table on the left, endometriosis-associated ovarian cancer patients had a lower median age of diagnosis of 51 versus 57. They were more likely to be nulliparous and tended to be diagnosed at an earlier stage at 79 versus 73%. Those without endometriosis were more likely to have a BRCA mutation or a BRCA variant of unknown significance. Race and ethnicity were largely similar between the two groups, with the exception of a non-significant high rate of Asian patients in the endometriosis-associated group. VT rates were similar, as well as recurrence rates at 21 and 25%. However, recurrence rates were significantly different when comparing the group by histology. 13% recurred in the endometrioid group versus 34% in the clear cell group. There was no significant difference in overall survival between those with and without endometriosis. However, there appeared to be a trend toward improvement of survival in patients with endometriosis, which fell away when controlling for stage. When comparing by histology, endometrioid had improved overall survival compared to clear cell histology and remained significant when controlling for stage. Our study is limited by the retrospective nature and sample size. Endometriosis is common in clear cell and endometrioid histologies, occurring in 2/3 of our cohort. Endometriosis does not appear to impact survival in our cohort, which conflicts with other data. However, this is likely due to the large proportion of stage 1 patients. Our clear cell patients had worse survival, suggesting histology plays a more important role, and all endometriosis-associated cancer patients are not equal. And molecular studies, including MMR status, should become standard of care, as it may impact eligibility for targeted therapies, as well as further studies needed to identify biomarkers that may help us better counsel and care for our patients with endometriosis and ovarian cancer. Thank you so much.